So, good morning, distinguished colleagues, ladies and gentlemen, all protocol observed. It is such an honor and privilege to welcome you to this important plenary session, and I do this with deep appreciation for your continued commitment to improving the lives of mothers and children in our country. I am especially humbled to be moderating what seems to be the first session. For the last 5 years, we've been meeting, but this seems to be the first session dedicated exclusively to newborn health. This is indeed a long overdue conversation, and I thank the organizers and strides we've made in reducing maternal mortality. We must also confront a hard truth. Newborn deaths remain alarmingly high, and this is why today's session matters. With 2030 fast approaching, we simply cannot afford to continue with business as usual. And so this space that has been carved out intentionally by the committee is a powerful opportunity to take stock, to challenge ourselves, and to align on bold, accelerated action for our newborns. Because every baby's life matters, and every death is one too many. So thank you for making time for our session, and on behalf of Save the Children and the entire panel, we welcome you to today's session. So, the theme of today's session is, what will it take to improve newborn outcomes through strengthening level 2 care and the experience we have in Uganda. And the objectives of the session are to discuss the policy environment for improving newborn care at level 2 facilities, to learn from the experience, from the implementation approaches that have been taken place in level 2 facilities through strengthening care, as well as introducing innovations that might help improve care. But we also want to hear from the providers, the people who are at the forefront. So a provider, we'll also have a provider joining us, as well as a client who went through the entire experience. Most importantly, we hope that this is the beginning of an important dialogue to advance newborn health. So, first, I would like to make things faster. I would like to invite the entire panel to join me on the stage. They're sitting here. So as you can see, we've lined up an exciting panel for you. I will try and do the best to moderate, but they are the experts, and they're the ones who've lived through this experience. And so to set the stage and context for our discussion today, I'll first introduce and invite our keynote speaker to join me, to come to the podium. And Dr. Kathy Bourgon, so I'll call her Dr. Kathy, is a UK-trained pediatrician who's dedicated her life to advancing neonatal care in resource-limited settings such as Uganda. And for over 11 years, she's worked in partnership with Mbale Regional Hospital and Born on the Edge, a foundation from the UK to improve outcomes for newborns in eastern Uganda. Kathy is passionate about simple, sustainable, and affordable solutions for preterm and vulnerable infants. She's going to be sharing a couple of those insights, and she will also help set the stage for what will be the rest of our panel. So Kathy, I invite you to, the floor is yours.
Good morning, ladies and gentlemen, honored guests, friends, baby miracle on the end there. Thank you so much for inviting me here today to speak to you at the National Safe Motherhood Conference, and for Dr. Winnfred for those kind words. It's an absolute privilege and honor to be able to stand on central stage today to represent the newborn. For too long globally, newborns have come second to their mothers. Their voices unheard, their deaths too easily ignored, and yet the first 28 days of our lives are the most dangerous. Today, I want to take you through some of the global data, some of the global evidence about what can work, what can help save our babies here in Uganda, and then give you a few insights experiencing neonatal mortality rates as high as 34 per thousand, for example, in West Nile, and other areas such as Karamoja with neonatal mortality rate, although not yet well understood, as low as 7 per thousand. At a rate of 22 per thousand live births, we still remain very far away from the Sustainable Development Goal 3.2, where we are urged to get our neonatal mortality rate to 12 or less per thousand live births. In 2023, the team from Makerere School of Public Health, together with Ministry of Health and other partners, published the latest situation analysis for newborn care in Uganda. And what they showed was this. Every year in Uganda, we have over 1.7 million births. Of those, 26,000 are stillborn. A further 32,000 of those babies die before they reach 1 month of age. If we look at the MPDSR data there in the pie chart, you can see that over 60% of our deaths are due to asphyxia, another 23% due to complications of prematurity. Deaths that can be easily prevented through access to specialized neonatal care. And the Citon also suggests that around 250,000 newborns need access to specialized neonatal care here in Uganda. And yet, we have not achieved in Uganda the 2020 targets for WHO, which suggests that we need to have 80% of our districts having access to 1 or more level 2 neonatal units. Here in Uganda, if we're going to reach the Sustainable Development Goal of 12 or less deaths per live births by 2030, we need to double our efforts, and we need to move twice as fast. Newborn care, why does it matter? It's not just about the neonatal unit. It's not about saving those tiny lives. It's about saving mothers, saving families, and saving our nation. Every time a mother loses a baby, she strives again and again, risking her life every single time to produce a baby that will survive and thrive. If we save, in turn, we save the mothers. Healthy babies mean healthy children, like baby Miracle here on the stage. Healthy children mean healthy adults, and overall we generate a healthy, educated, productive nation. They say that newborn health mirrors our health system. It's one of the clearest mirrors that we have because newborn care requires so many different elements. We need community care, primary care, right through to specialized neonatal care within the hospital. It involves antenatal care, perinatal care, postnatal care. We need functional ambulances, good referral systems. We need access to specialist equipment and supplies. When a newborn baby survives, it means that every link has worked. When a newborn baby dies, those links, they are weakened or they are broken. When we strengthen our newborn care system, we have the entire healthcare system for our whole population. Most of our babies in Uganda die in the poorest and most deprived communities that we have. Together, we need to strive to make sure that every newborn, no matter when they are born or where they are born, has equal and equitable access to specialized neonatal care. And if we invest in equitable newborn care, we are very far towards achieving universal health coverage. So I want to take you now to the vision of the Every Newborn Action Plan. It is a world in which there are no preventable deaths of newborns, no stillbirths, where every pregnancy is wanted, every birth is celebrated, and women, babies, and children survive, thrive, and reach their full potential. When we give be a time of joy and celebration, and yet as we have seen from the numbers, unfortunately for many, this is not the case. I'm going to take you through now some of the evidence that we can use to turn things around here in Uganda. In 2023, WHO and UNICEF convened a group of experts in newborn care to create a model for scaling up specialized newborn care for small and sick newborns. A lot of the evidence comes from countries in Asia like India and Bangladesh, where they have already achieved great strides in reducing their neonatal mortality. That they suggest has two pathways. You'll see the one on the right of the screen. Components for scale-up, they require political will and commitment, they require infrastructure, they require financing, and they require planning. I will focus today on the content of that care. But the key thing to understand here is that any specialized neonatal care that we implement has to go on the back of essential newborn care and widespread improved maternal care. But yesterday we heard that we are well on the way to achieving good maternal essential newborn care across the country, so we have set our foundations wisely. Some of the interventions brought up in that model I am going to focus on today, such as respiratory support with CPAP, immediate kangaroo mother care, family-centered care, and the need for training of our healthcare workers. I realize that many of us in the room are not clinical, but I will try and explain so that we all understand. We have seen that the leading cause of newborn deaths globally are complications of prematurity, and the second cause of our newborn deaths here in Uganda. Preterms suffer from what is called respiratory distress syndrome. Their lungs are not yet strong and developed to allow them to breathe sufficiently. In high-income settings, we can save babies as young as 23, 24 weeks, weighing as little as 400 and 500 grams because of access to mechanical ventilation and artificial surfactant. In settings like ours, these interventions are rarely available. However, there is a low-cost intervention, bubble CPAP. It was shown in a meta-analysis in 2016 that the implementation of low-cost bubble CPAP could reduce preterm mortality by up to 66%. Utilizing this knowledge and knowing that in Mbali Regional Referral Hospital, we were struggling to save preterm babies as big as 1.5 kilograms, we decided to implement bubble CPAP back in 2016. And what we saw was nothing short of a miracle. Babies who were previously dying were going home alive, well, and healthy. We looked back at our data, and what we saw was a reduction in preterm mortality in the regional referral hospital of 1%. I think the videos here speak more than words. The baby on the left is a baby suffering from severe respiratory distress syndrome, a baby who without support may not be here tomorrow. It's the very same baby in the next video, 10 minutes after being placed on CPAP, breathing comfortably and peacefully and having a chance to survive and thrive. The landmark study by the WHO of immediate kangaroo mother care turned upon its head everything we had ever believed about kangaroo. All of us believed that kangaroo was for big prematures, for stable prematures. But this randomized control trial carried out like ours, Ghana, India, Malawi, Nigeria, and Tanzania, on small and unstable preterms, showed that if we start kangaroo mother care in the labor ward immediately after the preterm baby is born, we can reduce the mortality of our preterms by 25% in the first 72 hours of life. In Mbali Regional Referral Hospital, we focused on implementing kangaroo mother care right from 2014, involving as best we could in the small space that was available. You can see on the slide on the right here, mothers practicing kangaroo and CPAP simultaneously. With the results from the IKMC study, we were able to extend our kangaroo mother care not just into our own labor ward and transfer babies within the regional referral hospital, but also to our surrounding healthcare facilities, where in 21 facilities we train them to implement immediate kangaroo and transfer both by ambulance in kangaroo care, meaning our babies arrive warm and safe. And with the regional referral hospital, we are now able to provide true family-centered care, where mothers and fathers are able to relax and have the space to provide 24/7 kangaroo. Breast milk is one of the most important interventions that we have available to our babies, even more so for our vulnerable and preterm infants. It reduces life-threatening complications when compared to formula milk, such as necrotizing enterocolitis, that small baby with a hugely distended abdomen you can see in the bottom of the slide. Compared to formula milk, breast milk improves our survival, it improves brain growth, and it improves our neurodevelopmental outcomes. And yet global data shows us that up to 40% of newborn babies in neonatal units do not have access to enough of their mother's own milk. WHO encourages us and recommends that we focus on mother's own milk, and we can do that through providing early lactational support, skin to skin, which encourages breast milk supply, and one-on-one lactational support. And where we still fail to have enough of mother's own milk for her own baby, safe, screened, pasteurized donor human milk is the next best option before formula. A few years ago in Mbali Regional Referral Hospital, we realized that around 80% of our preterm babies were going home with postnatal growth failure, essentially malnutrition in our preterm babies. What we were doing was not enough. We developed a bridge to breastfeeding program to implement those recommendations from WHO, focusing heavily on community sensitization, both through the health centers and through radio talk shows, providing a nutritional meal for all the mothers on the neonatal unit every day, and providing breast milk education to all the mothers in the unit, as well as one-on-one support. For those who still failed to achieve a good enough milk supply, access to screened pasteurized donor human milk was available until their milk supply became established. The last intervention I want to take you through today is in-service newborn care training. Many studies have shown that providing in-service newborn training can improve the quality of care that our newborns receive in hospital. However, the challenge is with sustainability and scale up. In 2014, Born on the Edge supported us to develop a 50 newborn care training course in eastern Uganda. These covered the key elements to provide specialized newborn care in a level 2 neonatal unit. A few years after it started, we realized that such structured courses were not available in similar settings and partnered with institutions in Malawi, Kenya, and Zambia. We were able to ensure all of those modules were peer-reviewed by experts in those countries and in the UK. In 2023, we were able to take those 15 modules and work together with Ministry of Health, Department of Reproductive and Child Health, together with experts in neonatal care across Uganda, to develop this into a 25-module in-service newborn care training. With support from World Bank and Sea Global Health, over the last 2 years, we've been able to train 162 neonatal nurses across, proving that in-service neonatal training is both scalable and sustainable here in Uganda. I want to take this opportunity to thank you all for listening. I hope that I have inspired at least one of you to make a difference, to make a change. We all play different roles in this room, whether we are frontline healthcare workers, policymakers, mothers, advocates, implementing partners. Together, little by little, a little becomes a lot, and we can save our littlest friends and help them survive and thrive. I want to thank Ministry of Health, NASMAC, and all the partners for convening what is the first plenary session on newborn care at NASMAC ever. Hopefully not the last. And I want to thank all partners and contributors across the country, everybody who is also striving to make newborn care a reality here in Uganda. And to all of you here today, all of our stakeholders who are here listening, learning, collaborating, networking, together we can make a change for every newborn. Thank you.
Thank you so much, Dr. Kathy, for that inspiring introduction to our session. And I hope she's helped set the foundation for what can now become where we can pick up with the rest of the panel. But I just wanted to remind ourselves about the challenge we've been given, right? So we've heard 1.6 births. We still have a staggering number of newborn deaths. We have about 250,000 of newborns who require specialized care. And for those newborns, they need that care at the right time, in the right amount for them to survive. And most importantly, I think what she really communicated was that it is feasible, it is doable, and she shared a couple of examples. But it is something that we're going to have to work collectively to achieve. And so I will now move on to introduce the rest of the panel, and then we can start sharing both the policy framework and the experience that we've had so far in implementing some of the interventions that she also alluded to. So our first speaker is going to be Dr. Deogracius Migade from the Ministry of Health. Dr. Migade is a senior medical officer in the Reproductive and Child Health Department, where he currently coordinates newborn and child health. He holds an MB, CHB, and MPH degrees, and he's the focal point person within the ministry for newborn and child health, where he leads work on strengthening implementation of newborn and child health interventions in the health sector. He's been at the forefront in the ongoing processes to scale up evidence-based interventions, including the development of guidelines and policies for child health, but also the capacity building of health workers, monitoring what's happening at the subnational level, and also supervising services and ensuring strengthening the functionality of the health facilities to deliver quality newborn and child health services. Dr. Migade will speak to us about the policy framework and the guidelines and plans that the Ministry of Health has for improving newborn health, including at the level 2 care facilities. Our next speaker, my colleague, Dr. Douglas Akibua from Save the Children, is a medical doctor and maternal newborn health specialist who's dedicated to advancing newborn survival and quality of care in Uganda. Dr. Akibua is the champion behind the project, the Saving Women and Preterm Birth Project, SWAP, and also he's also acting as health nutrition specialist at Save the Children, where he leads efforts to strengthen facility and community-based newborn care with a particular focus on preterm and small babies. Our third speaker, Dr. Santorino, is probably known to all of you. He's a Ugandan pediatrician, a senior lecturer of pediatrics and child health, and an inventor. His inventions in medicine have led to the award of 2 international patents from the World International Intellectual Property Organization, WIPO, but he's also been involved with multiple international organizations, including the American Academy of Pediatrics, the World Health Organization, as well as working with multiple ministries of health in developing and scaling up newborn progress. He's also a senior lecturer at Mbara University and the Uganda country manager for CAMTech. And then, most importantly, we'll have our provider, Frida Irwa, who works as a neonatal nurse at Kawala Health Center where she champions and serves as the lead for the special care unit and breastfeeding health initiative. She's passionate about delivering quality, holistic healthcare, and will be sharing her insights about the SWAP, the work that the project has done to strengthen care in her facility. And then, most importantly, we have with us Mama Nagawa Joan, the mother of Mama Miracle, who you can see her very busy, who survived a challenging birth at 28 weeks. And the baby you see here is her small miracle, who has survived that journey and is now not only survived, but is thriving. And so she will also be talking to us about her insights and her experience of the care that her baby received. So I look forward to the panel. One thing we'll go through the presentations, and they will take turns speaking, and then I encourage all of you to Do we have the QR code? Is it going to be brought up? So in terms of questions and answers, please note your questions and feed them into, get the QR code, the Slido QR code, and put your questions and we'll try our best to address them at the end. So if we could maybe have the QR code projected. And in the meantime, I'll invite Dr. Migade to get us started. Dr. Migade, the floor is yours. We are waiting for the slides to come up. I hope everyone is feeling warmer. When we first came in, I think they were trying to make us understand what hypothermia is, right? And I think hypothermia is a concept that we have not always appreciated, but very often is something that's preterm's experience. And unfortunately, their bodies are not ready to support it. All the energy they have is spent trying to keep themselves warm. And that's why we have to provide them that warmth. So I think it was a way of testing our resilience. But I hope you're feeling warmer now. We are. Sorry? I can keep it so busy. Oh, so maybe while we're waiting for the slide to come up, I'll start by I'll just start by sharing a couple insights, right? So someone's mentioned 20 years ago. We've been working on newborn health for the last 20 years, and I forgot to thank the many people in this room. I think at that stage, in 2005, it was a very small group of people who had the wisdom of putting newborn into a strategy document, and that initiated a discussion, led to the Saving Newborn Lives project at Save the Children, getting interested and providing some support and bringing together a couple of people. And I remember the first meeting was held in the UNICEF office, and I'm sure several of you, some of those who participated were there. So it's really exciting to see the journey that newborn health has had. I know that we have challenges, but there are a couple champions who've along the way tried to do what they could to keep things going, but it wasn't enough. That's why, and we need this type of dialogue to make sure that we can pick up that pace. So I think with that, maybe our slides are coming up. So the good news is that the technical issues should be done, and we will be given our time back. Thank you. So with that, the floor is yours, Dr. Migade.
Thank you very much, Winnfred. It's an honor to stand in front of you today to discuss with you from the Ministry of Health perspective what it will take for us to scale up level 2 newborn care. And I'm glad that I'm doing this presentation after the experience has been shared by Dr. Kathy. I think it has made my work a little bit easier. And I want also to appreciate my other panelists who are going to speak after me for this great time that we have taken off to discuss with you what we need to do collectively in order to improve newborn care in the country. So this has already been discussed. Like you're aware, we have had challenges over years in terms of reducing newborn mortality. Although over the last 5 years we made some progress, where we were able to have a reduction of about 18% from 2016 to 2022. However, the journey is still long for us in order to achieve our 2030 targets of reducing newborn mortality to 12 per 1,000 live births. And as you can see from that slide, newborn mortality contributes significantly, over 40% of all under 5 mortalities. So for us to be able to significantly reduce child mortality, we are supposed to collectively work together to reduce all deaths that are happening within the first month of life. We saw this yesterday from the annual MPDSR report, that again we have made significant strides in terms of reducing institutional perinatal mortality rate, now standing at around 15, with a lot of progress made in reducing the fresh stillbirth rate. And I've brought out this message clearly to show to us that we are collectively looking at every baby's life, right from conception up to the first month of life. We need to see that no baby is born dead and no baby dies within the first month of life. And our collective effort is to see that all these babies are saved and we bring an end to all the preventable causes of death. I'll start off with sharing some of the evidence that points to impact on scaling up level 2 care. And like we can see in this slide, we save babies' lives right from preconception, during antenatal care, during labor and delivery, the care for every baby, but also the care for the small and sick newborn. And you can see from the blue bars that we have significant babies that can be saved by just scaling up the care of the small and sick newborn. And this is where we have the greatest impact. We know, of course, care around time of birth, which looks at intrapartum care and neonatal resuscitation, has the potential to avert both early neonatal deaths, but also lives for the mother. But we can also achieve greater milestones if we are able to scale up inpatient care for the small and sick newborn. And this speaks to the level 2 care, as we shall see, and including kangaroo mother care and provision of continuous positive airway pressure, CPAP. And like what Dr. Kathy has mentioned, these are evidences that have been shared, and it's our collective effort to see that we are able, as a country, to see that each baby who needs these interventions is able to access them. So when we look at inpatient care for the small and sick newborn, it's not a standalone. Saving a baby's life starts from before conception, preconception. And that time, from birth up to 28 days, is just part of the entire continuum of saving a baby's life within the woman's and children's health. And this is what we are trying to demonstrate here. So right from preconception, at both community level, primary health care level, and tertiary care, we are able to have interventions that contribute to the life of the mother and the life of the baby. And going through the entire continuum of care up to when the child has gone beyond the 28 days. The component we are discussing today and what this panel is going to focus on, which is the inpatient care at both the primary service points and the tertiary points, is just part of a broader picture. And for us to build a system of newborn care as a country, we need to look at all these pieces together. We know that, for example, maternal well-being, maternal nutrition, the quality of intrapartum care greatly contribute a lot to newborn survival. And this is the picture, this is the message that we need to take out. Let's not think about newborn survival as those interventions that happen immediate after birth. let's not look at newborn survivors just neonatal resuscitation or providing KMC, but right from antenatal care, right during intrapartum care, the monitoring. Yesterday we saw the commissioner presenting about the decision to incision time having a great impact on the outcome of the newborn. So we are able to either make our babies survive or not survive even before they come to life. And this is evidence that we are sharing today. And again, Dr. Kathy has gone through this WHO model of small and sick newborn care, and I'm glad she has shared with us the content of care, which basically looks at the evidence-based practices we are going to do. My task today will be to look at the other side of what we need as a system to scale up. You know, we have the evidence-based practices that have been shared: kangaroo mother care, CPAP, inpatient care, capacity building. But in terms of the components that have been documented that we need to adopt as a country, these are the 10 models which we shall discuss in my presentation. And the first is of an enabling environment, the policies, the guidelines. We need to have a plan, and I'm happy to report that this is part of the work that we've been able to do. As a country, we need to know what we are going to do and in which period of time. And this is what we have as evidence 1. So evidence 2 is the financing. We know, for example, that putting all these pieces together to provide newborn care, the human resource we need, the infrastructure we need, the commodities we need requires financing. We need to advocate as key stakeholders in newborn care for more funding and more financing for newborn health. We know, as we've seen from the data, that newborn deaths are now the leading causes of deaths within our facilities as a country. And we cannot continue doing business as usual. We need to do more. And part of this talks about funding and financing, both from government but also from all our partners in this house. We've seen the evidence that the expert has shared with us, but now we need to collectively come together to see that this is scaled up to every baby who needs it. And the other one is human resource. Talking about human resource, we are talking about having the right HR for newborn, who are skilled and knowledgeable to provide newborn care, but also the right numbers and equitable distribution. We have over 141 districts in the country. We need to see that we have the right human resource in every country where there's every baby at all levels of care in our country. And then the infrastructure and designs. This is an evidence that we need to look at as a country. We have worked together collectively with the infrastructure department and other stakeholders to see that we come up with standardized designs and infrastructure for newborn care. So this is an evidence that is very key in scaling up newborn care across the different districts. And we are happy that, and we are requesting every stakeholder to come and support these efforts to see that once we have these standardized, we follow these for every baby to receive adequate care. And then equipment and commodities, I cannot overemphasize this, including the innovations, the evidence-based interventions that have been mentioned out, the CPAP, which is a key intervention for level 2 care, the medical commodities, including some of the core, the critical commodities for newborn, like caffeine citrate, surfactant. All these are very important if you are to talk about scaling up newborn care. And then ensuring that you have a very robust health information system right from the patient level up to program level. We have to have the ability to ensure that you have data for newborn collected and utilized at all levels, including patient-level data, aggregate data, and the most important thing is for us to be able, at all our levels, right from the neonatal units up to the districts and the Minister of Health, this information you are collecting about newborn should be able to be utilized and decisions made to improve care. The other important one is the linkage to maternal health, similar to what I've mentioned in my previous slide. We cannot save newborns as standalone without saving the mother. We know, for example, that birth asphyxia is the leading cause of newborn mortality. There's nothing much we can do about this if, again, we don't intervene from the maternal side. So for us to be able to design systems in our facilities as a country to reduce newborn mortality, we have to start from the maternal side. And that is very important. And then family and community. Newborn survival does not only end in our facilities or does not start from our facilities. There's need for us collectively as stakeholders for newborn care to build robust systems for community programs, newborn follow-up, but ensuring that also families are part of newborn survival. Very many babies are cared for in our facilities, but what happens after discharge? We need to see that we have a system that can be able to identify and follow up these babies to the facilities. And then finally, still linked to the communities, the post-discharge follow-up to ensure continuity of care. So again, just mentioning about the evidence, we know at the different levels, right from the basic to the secondary and the tertiary levels, what type of care should be provided and the interventions at the different levels. And this is not a standalone. This builds on the entire health system, our health cities. We know, for example, right from community level up to our tertiary level, we have mothers and newborns in the continuum of care. So right from the antenatal care, intrapartum care, and immediate care after every baby is born, we have services that should be provided at each level. Essential newborn care, very key for every baby. We've seen the evidence that it also reduces a significant number of deaths in this deaths happening among babies. Provision of KMC, skin-to-skin care, immediate breastfeeding, very important, including neonatal resuscitation. So neonatal resuscitation is very important, especially as we are battling with asphyxia in this country. But most important also, the quality of intrapartum care. Then looking at the secondary level, and I will again break down this, we have to provide continuous warmth for these very sick babies, but also scaling it up for airway support to provide continuous positive air pressure, among other factors. And then advanced care, where we look at more complicated cases, looking at mechanical ventilation, assisted feeding, among others. So this evidence is there, like what, again, Dr. Kathy has presented. And the task for everyone here in this room is to see how we are able to bring out this. So putting that in context, I will just share with you what, as a country, what as Minister of Health and the newborn stakeholders have agreed as our neonatal unit standards, based on that evidence that we know. We have agreed as a country that our care for newborns should be provided within 5 levels, reflecting the different service points we have, reflecting the different levels we have, right from health center 3s, where we expect to provide BMOC services. Here we expect to have a level 1 newborn care, mainly tasked with ensuring that you have stable babies, but also providing essential newborn care and neonatal resuscitation, but also the ability to identify sick babies, stabilize, and refer. So our level 2, which is the discussion for this morning, we have 2 sub-levels, that is level 2A and level 2B. And again, to fit within our health system and the structure, we are looking at level 2A being at the health center 4s, where we have the first special care units for babies. We expect to admit babies here, babies who need immediate attention, but also who are not advanced in terms of respiratory support. And then level 2B at general hospitals, babies who need additional respiratory support, including CPAP. We have level 3 at the regional referral hospitals, which we are calling the neonatal intensive care unit, which we look at having, we have level Level 2B is the high dependence unit, and then level 3 is the neonatal intensive care unit, looking at managing very sick babies who need intensive care and respiratory support, advanced respiratory support, including mechanical ventilation, in addition other support systems. And then level 4, the super specialized, including neonatal surgeries and more advanced care. So this is the framework under which we are calling upon all stakeholders to scale up and implement newborn care based on the evidence that we've shared with us. And we're hopeful that moving together with you, we are able to avert the deaths that we all want to reduce. So again, this is part of what I've discussed. And again, the recommended services, like we've said, are linked to the services that the health system is able to provide. And like we have seen, this newborn is not a standalone. We are fitting within the health system, and whatever services that make up the entire health system, right from the human resource to the essential commodities to the equipment that fit within our health system, is what we want these newborns to be based on. So based on that, on those standards, we are able to undertake and the functionality status to try and understand how we stand as a country in terms of these levels, in terms of the level 2 particularly. We've seen the evidence that this inpatient care can dramatically avert our neonatal deaths. But where we stand currently, we are able to undertake an assessment of all CMOC facilities in the country, public CMOC facilities, around 282 facilities, to try and understand where we have neonatal units and their functionality status. And of all the 282 facilities that were assessed, only 178, reflecting around 63%, had a neonatal unit, what we call a neonatal unit, space designated for newborn care. However, only 104% of these units, which is around 37, were fully functional, all operational. So this is still a big gap, despite the fact that we've made tremendous progress, but we have only 37% functional neonatal units in the country. And of course, there are other still challenges across these units, including the spaces that define the level 2, the triaging area being at around 42%, the KMC area being around 63%. So this is still a big challenge, and a call upon everyone to see that we keep supporting this. And again, for the different levels, for the health center 4s, you can see that that's where we have the lowest functionality status. At only 20.9% of all center 4s have functional neonatal units. And then general hospitals being at 73.7, and then our regional national referral hospitals all having neonatal units. And overall, at the national levels, we are standing at, like I've said, 63.9% functional. However, for those with neonatal units, that is at around 63.1. So we are looking at this availability of services in two angles. We have facilities which have units. We have facilities which have units and are fully functional. So our gap is to, first of all, ensure that everyone who has a facility, it is made fully operational and functional to provide newborn services, but also reaching out to those facilities that don't have space for newborn care services. So, and these are some of the key challenges that, again, we want to talk about. Again, workforce, HR for newborn, talking about the numbers, the equitable deployment. For example, we have around 5 neonatologists in the country, but majority of them are based in Kampala. We need to be in a situation where all regions have equitable HR. And then the nurses, which are very critical. Dr. Kathy has just shared to us about the in-service neonatal nursing training. We have only managed to train 192, but we need more. We need all these units to be equipped with skilled human resource for newborn. Infrastructure gaps, still a very big challenge, where we have space and equipment, and then supply chain, critical commodities. We have just revised our essential medicines list to include caffeine citrate up to general hospitals. We know this is a commodity that is needed both in prevention of apnea of prematurity and management. It means we need it in every facility where the baby is born, where a preterm is born. Surfactant is only available up to the regional referral hospitals. However, even where the availability has been made in the policy environment, sometimes we are challenged with stockouts, and then data for newborn. For so many times, the newborn data has been just part of the mother, either on the mother's chart, no newborn register, very well known. Birth asphyxia, still a very big challenge. Prematurity and neonatal sepsis. Yesterday from the report, we saw a very high number of low birth weights, even who are not 50% of our babies born with low birth weight are term babies. So it is coming out as a challenge on its own. We're having very many babies born to mothers who are term and are low birth weight. So we need to see how we intervene from the mother side. And then the access challenges, the geographical access, the community gaps we've mentioned, the lost follow-up. We have these babies born preterm, but we are unable to follow up in their community. So in terms of what Minister of Health has done and is doing, we are looking at this at a multi-level approach from both the national level, where we are doing at the newborn working group has been set up under the Reproductive and Child Health Department to oversee and manage all newborn work in the country, but coordinating with the National Referral Hospital and also the partners and all stakeholders to ensure that we coordinate newborn work. And then at the regional referral level through the local maternity and neonatal systems, we are ensuring that we conduct and oversee newborn work, including regional mentorships, learning networks to be able to see that one region is able to share with another, but also create a network of care, newborn network of care within regions. And then districts, like we've seen the levels, working with the district health offices, ensuring that we have health facilities take lead on newborn care, and community where we have both the VHTs and the CHUs, to see that we have a robust system of following up these babies, but also identifying babies who need referral. And all these are hinged among the policies and guidelines and the different strategies that we have come up with. The reproductive and maternal sharpened plan has prioritized newborn care, which again has informed the essential maternal and newborn care guidelines and newborn clinical care protocols. We have the child survival strategy, the newborn implementation plan, which is giving us a 5-year approach on how we are going to handle the issue of newborn survival for the next 5 years. And then the ICCM strategy and the community health strategy, which we are hopeful we shall be able to use to guide our implementation for the community. And then finally, like I've mentioned, this is a multi-pronged approach. We cannot avert newborn mortality with just one single intervention. There's no one magical bullet that can really bring down these deaths, except if we address all the challenges, like we've mentioned, and using an integrated approach right from the maternal side. And this is what we've done as Minister of Health and as the Reproductive and Child Health Department, working together with all the stakeholders in this room to ensure that we are able to create those facility linkages, to address issues of infrastructure and equipment, the evidence-based practices, the building health workforce capacity from both pre-service and in-service. And we're happy to report that this year, again, we're able to approve the neonatal fellowship program for this country to be able to train neonatologists within Uganda here. Our first cohort will be graduating, but we also have taken another cohort, and we're hopeful that this eventually will build up in required numbers for having neonatologists. But also in service, we are doing the comprehensive in-service training and mentorships, and focusing also on issues of data, partnerships, and mobilization, very important. We need everyone to move with us to see that we address newborn mortality and survival. Thank you very much. I want to appreciate the moderator and everyone and all of you for the work. I know we've done this with everyone. Thank you very much.
Thank you so much, Dr. Migade, for helping set the stage. So I think clearly he has shown that there is no silver bullet for saving newborns. However, I think the recurring thing is that it seems daunting, but it's feasible. We need to get things right to recognize that we're looking at a pyramid. So if we looked at that, where we start from, right, from the health center threes, if we do essential newborn care properly there, then we start reducing the number of newborns who need specialized care, and then we can ensure that our regional hospitals are not as congested as they currently are. However, it also shows that we don't wait until that baby's born to start scrambling. It's not the work of pediatricians or the people who are trying to save the babies. It's the work of everyone in this room, and it starts with the mother. It starts with the care she gets during pregnancy. Most importantly, the quality of care that she gets during her labor. And then that's where we can see the greatest reduction in newborn deaths and improving survival, and then the postnatal care that's needed for those babies who now need critical care. So clearly we have a clear foundation here, and it's also showing the plans that the ministry has that involve everyone from the community up to the highest level, up to the national level. Everyone has a role to play. So with that, I will invite Dr. Douglas Akibua to tell us about some of the experience that the SWAP project has had in trying to address some of those issues at Health Center 4s in Kampala. Just for the committee, are we going to get the Slido QR code at the end, or are you going to show it in between some of the sessions? Because I know people have been jotting. There it is. Thank you. So feel free to send your questions in.
Okay, thank you. Thank you very much, moderator, and my fellow panelists. I will ride on the already existing protocol, and I'll be sharing with you our experience and casting light into one of the programs that we implemented in the Kampala Metropolitan Region through the Kampala Metropolitan Local Maternity and Neonatal Systems for the region. So that is the team that participated in this work that I'm going to present. One of them could be seated next to you. So we call SWAP, and its goal was basically to improve the survival of small and sick newborns and pregnant women with complications leading to preterm birth. The project is premised around 4 major objectives, and that is improving identification of mothers at risk of preterm birth, improving essential care for newborns and facility-based care, as well as utilization of data and QI for the different processes and management of small and sick newborns in the different facilities. As earlier mentioned, this program is in the Kampala metropolitan area. We are in 3 health facilities in Kampala, and 1 in Mukono and Wakiso each. And we chose those facilities basing on the volume and burden of the maternal and newborn conditions, as well as the volumes of referrals that we are going to the high-level facilities, and that is majorly to Kawempe National Referral Hospital. We did work with partners, the Ministry of Health, both local district governments of Mukono and Wakiso, Kampala Capital City Authority, the Value Global Health, and eWorld Technologies to be able to advance the work that we did in this area. So, as part of the approach that we used, the previous speakers have mentioned aspects of training, they've mentioned aspects of mentorship, and specifically to be able to achieve the goal of this program, we are able to focus on improving the quality of care of women at risk of pre-eclampsia and eclampsia, because these are some of the conditions that have the highest risk to women who are likely to deliver preterm babies. And in that, we focused on training frontline healthcare workers on the Helping Mothers Survive modules. As you can see, the different suites of training for the management of preeclampsia, eclampsia, bleeding after birth care, threatened preterm birth, and essential care for labor and birth. And in order for us to improve newborn care, we did establish and functionalized newborn care units and focused on innovative technologies to improve the survival of newborns. You're going to be able to look at some of those technologies and see what they're about. I know some of you might have already seen some of them at the booth or at the presentation that we were able to have yesterday. And we also advanced the Helping Babies Survive suite of trainings with the different packages. And through all this, we are able to have cross-cutting activities or approaches around capacity strengthening, infrastructure, and technology, where we're able to provide equipment, train the health workers to use them, but also support with the maintenance of the equipment that have been provided. We also supported or worked with the different structures in the different health facilities to use data for quality improvement, but above all, for them to be able to make decisions, both at facility and at district level, to improve maternal and newborn care in those facilities. Those are some of the technologies that we utilized. That's the Neonatal Live. It's a skills trainer for neonatal resuscitation that gives health workers instant feedback and just to improve the skills of resuscitation. We've seen the causes of newborn death. Birth asphyxia is top in the list, so this is a key priority that we're able to focus on to improve those results. The other is the CPAP. We've been hearing recommendations of CPAP since we started this conference yesterday, and that is the continuous positive airway pressure device that evidence has shown that it improves survival of newborns with conditions that is able to manage. So we utilized the variable CPAP, which is a low-cost device. Compared to conventional CPAP devices, it doesn't need electricity. It has movable parts and can be used during referrals, in addition to being able to blend the oxygen that it provides to the babies. If you have the chance, please join us at our booth. You'll be able to see how this device works and be able to have a number of questions that you have answered. So, to share some of the selected key results from this intervention of making functional these level 2 facilities where we're working and being able to train health workers, mentor them, provide equipment, what are we seeing? We are seeing that over time, these facilities are able to take care of these babies, and the admissions in these units are increasing. That's not the only interesting bit. We're also seeing that referrals are significantly reducing from these sites, meaning that the higher level facilities now have fewer unnecessary referrals going to them. They're able to focus on the few cases that go to them and provide the best of quality. And not only that, even the ones who are referred, they're referred because they are in very critical condition, but their survival has also been seen to improve. And you'll be able to see this in one of the sessions that we have this afternoon to dive deeper into this work around the outcomes. We also acknowledge that you cannot improve the survival of these newborns if you do not cause an impact on the mothers. That's why this project looks at both mothers and the small and sick newborns. And so through the band of interventions, we are able to improve some of the key evidence-based maternal interventions. As you can see, the use of antenatal corticosteroids, as well as provision of magnesium sulfate to mothers with preeclampsia and eclampsia, and having them improve over the time of the intervention. And looking at the outcome of the babies that were initiated on this low-cost simple device, we see that babies over time having their outcomes improved and weaned off successfully from this device that utilized. I know those who attended the session on CPAP were able to see this. So yes, this device can also support the survival of newborns alongside the other interventions. And as you can see here, using some of these devices, we are seeing over time, babies are being weaned off successfully and the deaths are reducing in these facilities. In terms of kangaroo mother care, we are also able to support the health workers to have this increase. You can see across the 5 sites, KMC was overall below 15%. And at the end of the program, we are seeing them soaring at almost 60% across the different weight categories. These are proven interventions that if we institutionalize them and expand them, they can really improve the survival of small and sick newborns, as well as the mothers who are likely to give birth to preterm babies. So we believe that strengthening level 2 care from the evidence that we've shown reduces unnecessary referrals to tertiary institutions. Low-cost technologies and devices can easily be adopted by the providers to improve this care. And we have also demonstrated the possibility of increasing uptake of underutilized high-impact MNH interventions, for example, the SCS and the mag sulfate for preeclampsia, eclampsia. And above all, we saw from yesterday's presentation, Kampala is one of the districts where the outlook is not very good. And so we believe that if we render level 2 care functional, we can improve the outcome of our mothers and newborns, and also contribute towards accelerating the achievement of the 2030 goals. Thank you very much, and we'll take any questions after.
Thank you. Thank you so much, Douglas. And as I invite Dr. Data to come up, I will say that last week we visited Kawala Health Center, and I was really impressed by the feedback that the in-charge said. She said, now that we have better capacity, we are able to take better care of our babies and we don't have to refer them. She was so proud that she was able to do that in-house. So this is what we're able to see. These are the promising results, and hopefully this is something that we can continue to scale up. With that, I invite Dr. Santarino Data to share, to talk to us about digital innovations and newborn health.
Good morning. So my presentation this morning has 3 key concepts: innovation, newborn, and quality of care. And during this presentation, I would like us to take a moment to reflect on what we are measuring for the newborn, regarding innovation, and regarding our quality of care. Let me start with quality of care. So the World Health Organization defines quality of care in many parameters. It says the care should be of good quality if it's effective, it's equitable, it's safe, integrated, people-centered, and timely. And it's geared towards achieving the outcomes that we want. So, if we are to have good quality of care, we must be committed to be able to measure quality of care. Because if we can measure quality of care, then we can be able to move towards the care that we want, or sustain the gains that we have achieved. And so to effectively measure quality of care, we need to be thinking about strengthening our health systems in terms of infrastructure for things like health information. We need to think about what we are measuring and how we are measuring them, and whether we have the capacity to be able to internalize what we are measuring. So for newborn care, if we are to do good quality of care, we need to be able to perform our measurements in 3 different buckets and perform those measurements in all the 3. So we need to be measuring our infrastructure and the inputs that go into that. We need to be able to measure the processes, but also we should be committed to measure the outcomes in the ways that optimize what we want in healthcare. So for newborn care, let's look at first the giant killers of our babies and the giant interventions that we need. One of the giant killers is birth asphyxia. The second one is complications of prematurity, and the third one is infections. They really look giant. But let's then focus on the known giant interventions we need to deliver. They actually sound so simple. We need to keep the babies warm, we need to support their breathing, and we need to feed them. And when we do these 3, we need to make sure that we are preventing infections and we are treating these things we need to improve and things we need to improve and things we need to prepare for. So instead, in terms of prevention, we need to be committed to identify high-risk pregnancies and be there to respond to every birth. In terms of performance, we need to be able to deliver quality newborn resuscitation. In terms of improvement, we need to be committed to improve the quality of newborn care we are doing. And we need to prepare health workers to provide all this. What is the challenge of our time? The challenge of our time is that when we train health workers, immediately after training, 20% of them will fail. So time is life for the baby who is born not breathing. And so I'd like to show you an innovation that we can be able to measure our processes so that we are better prepared for the outcomes that we count. The augmented infant resuscitator gives you real-time feedback on your quality of ventilation. So green is good, red is bad. Now I'm in effective ventilation. If the airway was blocked, it instantly tells me that there's airway blockage. If I unblocked it, it shows. There was excessive air leak, it instantly tells me so that I can fix it. Now I'm in effective ventilation with a normal rate. If I started bagging fast, it will show me so that I can slow down. And if I was bagging really hard, it gives me that yellow warning sign so that I can go more gently on the baby's lungs. This device acts like my electronic coach. So when you use the air device for ventilation practice, immediately after your practice session, it will tell you what you have done well and what you have not done so well, so that you can be able to improve. At the health facility level, it can be able to tell you how many people in your facility are supposed to be practicing, how often they are practicing, who is practicing, and the quality of their practice as a facility, so that we can measure the processes. We have used the air device in the swap facilities in Kampala and also in many other countries. And now, I would like to tell you what the results are. This data is for 2024. And in 2024, after many years of practice, you can see that our health workers are 20% proficient before training in newborn resuscitation. After training, their proficiency went to about 50%, and they were able to maintain that proficiency up to 11 months. This is not a story unique to Uganda. When the studies were done in Kenya and India, health workers were at less than 20% proficiency before training. They went to 50% proficiency with the training, but in Kenya and India, they were able to push with the use of this device to achieve 86% proficiency at 6 months. The same thing happened in South Sudan. So for the first time in history, we can be able to say skills decay, which has been our big problem, we can fight it. And we can now talk about skills growth post-training. Coming back to the giant killers, we talked about birth asphyxia. One of our giant interventions is breathing support and how we can do that. But think about warmth, think about feeding, and think about infection prevention. How can we be able to measure this? What are we measuring? When it comes to this, our health information systems can play a role, and we need to strengthen that. And with the SWAP project, and we introduced PRISMs. PRISMs is a clinical decision support tool that gives health workers a framework of how to examine these babies. And using these assessment findings, it tells them what they need to do in the primary message and how they need to do it. PRISMs has the potential, as you use it, to seamlessly collect quality of care data so that you can be able to prospectively follow up these babies. At a click of a button, you can know whether the babies are growing well. And it has a feeds calculator and a patient-specific menu. At your facility, as you use it, you can be able to get data on how quality of care indicators are looking like just at a click. So PRISMs brings quality improvement to the bedside. If you have held your hands together to collaborate across institutions, then you can be able to use the PRISMs dashboard to compare the quality of care across your facilities so that you can be able to engage in meaningful collaborative learning. With this technology, I can sit in this room and I do a word round with somebody in Modrator. Very meaningfully. In terms of data quality, this is data from one of the hospitals that is using PRISMs. When they started, the growth of their babies, 50% of them were excessively losing weight at the beginning. But over time, they transitioned most of their babies to be growing inadequately. And I'm sure with consistent quality improvement, they can be able to have more babies that are growing adequately. But this is information they don't need to spend time collecting. They just need to use the technology, and at a click, they are able to visualize it. This technology has elements for ensuring data quality and completeness. So as you use it, it can be able to tell you which aspects of your data collection tools are complete and not complete. It can give you ideas of whether your discharges are completed, because if your discharges are complete in the system, then you can be able to understand what are your main drivers of neonatal mortality in your facility. This is real data for one of the hospitals that are using PRISMs, and so you can see early neonatal sepsis causing 51% of the admissions in that facility. And if we know that, then we know that we need to work with this facility to strengthen their infection prevention. And this is data the Ministry of Health now has information, access to, the facilities have access to, and we can then be able to work together and solve this. And so, as we think about quality improvement for newborn care, we should remember that as we enable health workers to acquire skills, we need to be deliberate to ensure that these skills are maintained and that the health workers are empowered to act effectively, and we are measuring these processes objectively. Thank you so much.
Thank you so much, Dr. Santorino. So feedback is important and data is powerful, right? And my hope is that in a future NASMEC, we can see those retention skills, the post-retestation skills go higher than some of the countries that are our neighboring countries. I'm very competitive and I hope you all are. So at least we have a goal, right? So with that, I would like to invite our champion provider, Frida, to talk to us about her experience working at Kawala Health Center in a newborn care unit. Frida?
Good morning, ladies and gentlemen. I'm Ira Frida. I'm a nurse, a registered nurse working with Kawala Health Center 4. And working with a special care unit. I'm an enrolled nurse by training, but by appointment, I'm a registered nurse by training at the moment, but by position, I'm an enrolled nurse. And I'm also currently heading the special care unit of Kawala Health Center 4. So Kawala Health Center 4 is one of the KCCA health facilities that is located in Rubaga Division. And it's a very busy health center, delivering about 800 mothers every month. And our neonatal unit makes admissions of approximately 150 babies every month. But then when you look at these numbers, and then when I talk about the unit that we're actually making all these admissions in, then you'll really wonder how well we are doing and how well we are trying our best to save these newborn babies. We work in a small room, which takes about 7 beds. And when I talk about the 7 beds, it's not really the ideal spacing of these beds, but then we make sure that we are having all these beds because of the number of babies that we admit. This facility didn't have this unit until 2 years ago under the SWAP project. So when the SWAP project came into Kawala, we didn't have space. And the bachelor room we are talking about was actually accommodating 2 mothers or 2 beds for post-cesarean mothers. So we looked for space and then we decided that we can always start small. And that's how the unit was born. And that unit was equipped by Save the Children under the SWAP project. But then it took about 4 months to kick off. Sorry. So the equipment was there, but there was no one to work in it. And as you know, the complexity of this neonatal care, not everyone has the knowledge in it. And I, as well, didn't have the knowledge in it, but I had the passion and the interest. So when my in-charge approached me and said, can you take this up? I was like, I have no training. But she was like, yeah, you go, but you're going to learn. So I accepted to go there as a one-man army, operating day duty, and then always moving my babies to Kawempe every evening. So I was more like a transport officer every day. So I was working there under the mentorship of Save the Children because I had an on-site mentor who was mentoring me all around. So I worked like that for about 2 weeks, and then a colleague joined me where we're doing day and night, and weekend, we offload our babies to Kawempe. So when I talk about it right now, I'm very proud because Kawala Health Center unit, special care unit has really grown. Our referrals have really come down from a point where we didn't have a unit and all sick babies were being taken or referred out to a point now that we can have less than 10 referrals in a month. So this is really a very great achievement for us. Yeah. And our unit at the moment is really well equipped with all the machines that we need. We have the phototherapy machines, we have the incubators, we have the resuscitation machines, and all these were provided by Save the Children under the SWAP project. We're also working on our babies, saving them remotely using the technology that Dr. Data has just talked about, the PRISM, and then we have the air device that helps us to improve our skills on ventilation. So I would like to tell this house that when you come to Kawala Health Center unit, special care unit right now, we are paperless. The only thing we have is the HMIS register, discharge letters, but then anything else concerning baby reports or files, we don't have. So everything we are doing right now is more of technology, and that is really thanks to Save the Children and then the innovation by Dr. Data and the team. We also have saving our babies using value CPAP that has been brought by Save the Children under the SWAP project. As we have all seen, most of our referrals were because they needed CPAP, but as a health center 4 and a level 2 NICU, or special care unit, we have about 7 CPAP machines that we use to save our babies and avoid referrals. So all that is beautiful, but however, we also have a few challenges, and one of them is the human resource. At the moment, we have 4 staffs running that unit 24/7. But then anytime you come to Kawala Health Center, you won't have a day where there's no health worker working, and they're always working long hours. So really, we are doing our best. Our issue is also in the space with the growing admissions. We are just having a room of about this size, and it's really not enough, and that's a big challenge. We get stocks out of drugs, and then since it's a health center for the drugs that we don't get, which are so essential for the newborn unit, such as caffeine, citrate, we don't get second-line antibiotics, and so on. Sometimes we also get challenges with refilling our oxygen. My recommendation would be, since there are few trained neonatal nurses, or in Uganda, it's just something which is coming up, I would really advocate for Ministry of Health to look into this and bring in courses that people can do, or the passionate nurses can do to specialize in neonatal nursing. So after getting into neonatal nursing, I swear I wouldn't want to go anywhere else. So I would really ask Ministry of Health to look into this so that they give us these specialized courses, even at diploma level, so that someone follows their passion all through. Also, we'd also ask that we get easy access to state scholarships so that we can upgrade in our studies and get specialized in neonatal care. The other one also, it could be to improve recruitment and retention of these neonatal nurses. So most times we are having trained neonatal nurses who are very passionate, and then before you know it, they have been transferred to a health center facility which has no neonatal care unit, or to a department where they have nothing to do with newborns. So we end up wasting these talents if they're actually very rare. Also, for Kawala, with the numbers that we are having, if the Ministry of Health could upgrade this facility to a general hospital and enlarge it and give it enough infrastructure and human resource, it would really help the mothers and the babies in Kampala metropolitan area. And then also creating wage and opportunities to promote these health workers who are working in these units, working on mothers and babies. My unit has registered nurses all working in it, but then all of them are working as enrolled nurses. They are very passionate, they are very knowledgeable, but then as a sign of motivation, during these recruitments and promotions, I would really recommend that the ministry looks into this and promotes them. I would like to acknowledge at the end of my presentation the management of Kawala Health Center for giving me this opportunity to work as a neonatal nurse and for accepting Save the Children under the SWAP project to start this unit at the facility. I also want to acknowledge KCCA management for allowing this. I would also like to acknowledge Ministry of Health for giving the accreditation for Save the Children to start this project in Kawala. And last but not least, and most importantly, I would like to thank Save the Children for choosing Kawala as one of their facilities that they have put this neonatal care unit. And as I'm talking right now, the SWAP project has come to one end. That leaves Kawala running without an IP, helping if there's need, supporting and all that. So I call upon the different stakeholders here, if they're available here, to come to Kawala and help us take the work that the SWAP project brought in. Thank you very much.
Thank you so much, Frida, for being such a strong advocate for the excellent work that Kawala Health Center is doing, but also for showing that when the facility is given the opportunity and support to make a difference, they start taking, appreciating them and owning them and demanding more. So you heard her. She's asking that the neonatal nurses, the newborn nurses be trained and retained, and she's asking that her facility be given continued support to sustain the results they've been able to achieve. So finally, we want to invite Mama Joanna to talk to us about her experience. I forgot mine. Just because this last session is probably the most important one, because it shows us why we've been doing this, why it all matters. You saw baby Miracle running around. I'm sure she's probably resting somewhere. But hopefully we can now hear from her mother about her experience and her journey throughout her pregnancy and the care that she received in one of the facilities that the project has been supporting.
Good morning, ladies and gentlemen. By names of Nagawa Joan. My short story about my pregnancy and my child right now. I got complications on my pregnancy at 6 months. I got a complication that I didn't know, and I had no idea what was going on with me and with the pregnancy. My water broke. So I didn't know about it since it was my first pregnancy. I called my elder sister to ask her what was going on with me. So her first question to me, yambuliza olubuto lwa bbanga ki? So I had to answer her 6 months. She got scared. Nagamba, that is so bad. Amazzi gava ku muntu atuuse nga she's ready to deliver. They had to call my mom. Ne bantwala to the nearby clinic. When we reached there, the nurses we found there, they had to first check. We bakeberanga the truth amazzi gagwa ku mwana naye nga ate nabaneeganyo teri open. They had no other choice. Ne bampa first aid, first treatment. Ne bagamba to save the child from getting infection. After then, they had to refer me to Nagro Hospital. When we reached to Nagro Hospital, it was a Sunday, but doctors were off, so it was a bit hard. From there, I had a connection with one doctor who helped me. We had to call him. I thank God he came immediately. So when he reached to the Naglo Hospital, he took me direct to the scan. Nibakebera, the baby was there alive. Nayenga amazzi gamuweddeko ate nga nabaneeganya okwegula. So from there, they took me to theater. They did the operation. Never jammed the baby. The baby was okay. She was alive. Never mukora the first aid. Never mpima. She had 1 kilo. Never mute immediately. Never mutwala in special care. From there, the other issues I had to just ask after. Bamtekela ku oxygen, CPAP oxygen, where she took a long period of time, over like 2 months, as she's on oxygen. It was really a tough time. But I thank God she survived. She spent a long period of time on oxygen, on CPAP oxygen. She had a lot of complications since she was very little, she was young. She had complications. The doctors told me she had a complication with the heart, but they didn't know what was the major problem because Nagro Hospital, they don't have where they could do the checkup to see what is really wrong. They had to wait until one was able to breathe from this free oxygen because they couldn't take her to Mulago Heart Institute when she's on CPAP. We had to wait until we attended her to gain, to recover, to be able to breathe on free oxygen. When the day reached nga sobola okusa on free oxygen, they organized for us. Ne batutwala to Mulago Heart Institute to check what was the problem. From there, they found out that she had 2 holes on her heart. Naye ba Dr. Tebatutisa, they told me since she was a premature, as she was growing, those holes will recover slowly. Nebatwa some medication, then they sent us back to Nagro Hospital, and she was put back on oxygen, on that free oxygen. And we waited for a long period of time again, okubera nti asobola okuva ku that oxygen to be able to breathe on our own. But the day still came. The doctors in the morning, they came, they first did the test to see whether she can be able to breathe on her own without oxygen. And that was approaching to almost 3 months. We were in hospital. We thank God they removed her, so I had to review her for almost a week, and she can breathe on her own. From there, I was able even to hold her, because during the period she's on CPAP, I couldn't hold her. I couldn't do anything. But after she's off from oxygen, I was able to do kangaroo. I was able to put her on my chest to be with her, to train her how to breastfeed, to suck the breast. And thank God she responded very well. From there, they monitored us for like 1 week again before discharging us from the hospital. After that, we are discharged. We are sent back home. Then they told us to be coming back for a review. We did a review for almost a year. I take her until she made a year almost. When she made the year, we were discharged completely. And she has no any complications. And she is very well. But all in all, I thank the nurses and the doctors of Nagul Hospital. And I thank the group of the organization of Save the Children for providing the equipment in the Nagul Hospital, that oxygen, CPAP oxygen. Because honestly, if it was not CPAP oxygen, I think my baby would have not survived, because she couldn't breathe on the free oxygen they had. It was only the CPAP oxygen worked for her at that period of the period we spent the 2 months she was on that CPAP oxygen, which helped her lungs to be able to breathe, because it was really hard. It was hard for her. I thank the group of Save the Children for the good work you've done, for the equipment you've provided in the different hospitals, because I believe it's not only Nagul Hospital, even other hospitals, because it's really good, because the children, there are very many children who are really hard, that they could not survive from the free oxygen. They needed CPAP oxygen to survive. I really thank you so much.